and Dr. Tamara Rordorf will present. And still with this cause, I think this is really a very promising technology, and there will be a lot of different types, so we should see that we have also a lab here in Zurich. Tamara.
Thank you very much. Well, head and neck cancer has not been traditionally considered the first disease you will think of in terms of being immunogenic or responsive to immunotherapy. But still, there have been trials in the last 20 years and endeavors to include immunotherapy in the treatment of head and neck cancer. And of course, within the last couple of years, there have been some new trials with new substances. So I would like to start with going through some epidemiological data and molecular feature of head and neck cancer, and remind you that head and neck cancer is a heterogeneous disease. The majority of the patient has what we call traditional risk factors. These are smoking, excessive alcohol consumption. These are mostly elderly men with comorbidities, with cancer occurring anywhere in the upper aerodigestive tract, and those patients have worse prognosis. And then there is another group. These are the patients who have HPV, human papillomavirus associated disease. This disease is a sexually transmitted disease, and the location is almost exclusively oropharynx. The patients are younger, there are more female patients in this group, and the patients have in general better prognosis. So those two subtypes are not two different diseases only in terms of epidemiological, clinical features and the prognosis, but as Cancer Genome Atlas group showed, there are two different diseases on the molecular level too. So what you can see here, is the genomic map of head and neck cancer, showing on your right-hand side this cluster here, HPV positive disease. As you can see here, it's located mostly or almost exclusively in the oral cavity and oropharynx. And if you look down, you see that there are not that many mutations in the HPV positive head and neck cancer. If you look at the bigger part here, which are the patients with classical head and neck cancer, you can see that there are more mutations in general, and then particularly that in this group of the patients, P53 is mutated in almost all of the patients. The second common mutation is the cyclin-dependent kinase N2A, and it's present in about 25% of the patients. In the group of HPV positive patients, the only mutation that's rather common is a PI3 kinase that's mutated. In regard to P53 and the CDK N2A, it's important to point that these are not oncogenic drivers. These are loss of function mutations, meaning that it's difficult to target them, and of course that makes the therapy of head and neck cancer more challenging. You have seen this slide before. What it shows us is that the higher mutational load in cancers like melanoma and the lung cancer makes them in general more sensitive to immune therapy. And you see that head and neck cancer is not one of the cancers with the highest mutational load, but still there is a significant number of the mutations. So does this make head and neck cancer a potentially immunotherapy responsive disease? These are some, or the substances from the trials done in the last 20-25 years. You see that interleukin has been tested in this disease, interleukin 2 and interleukin 12. were both given into the tumor or into the lymph nodes. And this was then followed by surgery and radiation. And there were actually some positive results showing a tumor shrinkage, which was then followed by standard local therapy. There have been some trials done with interferon gamma with conflicting results, and then the era of the monoclonal antibodies came. Except monoclonal antibodies, there have even been trials with adoptive cell transfer done more in nasopharyngeal cancer than in the classical squamous cell carcinoma. And there have been also trials with anti-tumor vaccines, different kinds of them, dendritic-based, whole tumor vaccines, peptide-based like MAGE-3, and so on. So, talking about monoclonal antibodies, all of the antibodies tested for head and neck cancer target EGF receptor. EGF, or epidermal growth factor receptor, is overexpressed in 90% of head and neck cancer. High expression, however, is associated only with a worse prognosis, not with a better response to monoclonal antibodies. Activation of EGF receptor triggers a downstream signaling pathway with activation, stimulation of transcription, cell cycle, and the cell proliferation. And obviously, blockade of EGF receptor causes the opposite. Now you see here on the cartoon, you see several of those antibodies that have been tested in clinical trials, some of them in combination with chemotherapy, some of them with, all of them almost with radiation. And only cetuximab actually find its way to clinical standard treatment of those patients. Cetuximab showed, in combination with chemotherapy for recurrent or metastatic head and neck cancer, improvement of overall survival when compared to chemotherapy alone, and when combined with radiation in curative treatment, it improved overall survival compared to radiation alone. So there's the question how cetuximab actually works is quite intriguing, because obviously when you block the receptor that has tyrosine kinase effect, you expect actually the efficacy to occur by blocking those signaling pathways. And these are the important pathways that are downstream of EGF receptor. This is RAS, RAF, MEK, ERK pathway that stimulates transcription, and it's PI3 kinase pathway important in apoptosis. But still this question, why does only a small percentage of patients respond to cetuximab, although the expression of its receptor is so high? This somehow led the head and neck community not to really believe that this is the mechanism of action. So what's believed today is, and this is very, very simplified, so I'm apologizing to all immunologists here, but the idea is that when cetuximab binds and coats the tumor cells, the constant region of the antibody can bind to the antibodies of different immune cells, including NK cells, and this complex leads to lysis of those antibody-coated cells, being tumor cells. So this is believed to be, the mechanism is called antibody-dependent cell-mediated cytotoxicity, and it's believed nowadays to be at least to some degree responsible for the responses we see with cetuximab. So now, checkpoint inhibitors. In head and neck cancer, there have been trials with single substances, with nivolumab, pembrolizumab, and durvalumab. And there are trials, all of them ongoing, in combination with checkpoint inhibitors with vaccines. checkpoint inhibitors with chemotherapy or the combination of 2 checkpoint inhibitors. Most of trials are still recruiting. Some of them completed recruitment and are presented. Very few of them are already published. This is the list of the trials in head and neck cancer. And I would just like to point out, well, the blue arrows are actually showing the trials that we have or had or are going to have open at the university, here at our Department of Oncology. So what you can see is, for example, pembrolizumab first line compared to extreme scheme in the first line treatment of metastatic head and neck cancer. Other trial is TVEC compared in combination with pembrolizumab as a second line treatment. Both of those trials are recruiting at the moment. Then we had nivolumab, second line, phase 3 trial that stopped recruitment and has been presented at AACR and ESCO this year, hopefully soon to be published. And then the 2 trials in cooperation with the Department of Dermatology phase 1B trials. So these data have been presented at AACR and then later at ASCO this year. And this is the largest, it's phase 3 trial for the patients who have recurrent or metastatic head and neck cancer and have been treated with platinum already. So what you see is that patients have been randomized 2-to-1 to either nivolumab or one of the chemotherapies which we use most commonly as a second-line treatment in head and neck cancer. So about half of the patients received docetaxel, about 40% received methotrexate, and about 10% were treated with cetuximab. The primary endpoint was overall survival, with progression-free survival and overall response rate being the secondary endpoints. And this is the result of the primary endpoint. This is overall survival for the whole population. And what you can see here is a survival improvement from 5.1 to 7.5 months with a hazard ratio of 0.7 for the whole population. This was statistically significant. When the investigator looked according to PD-L1 expression, the results showed a statistically highly significant improvement on the overall survival with hazard ratio of 0.55 for the patients whose tumors expressed PD-L1 for at least 1%. So you can see that it improved, the survival improved from 4.6 to 8.7%, which is for head and neck cancer in second-line treatment really a good result. In the PD-L1 negative or patients expressing less than 1 PD-L1, there was no difference in overall survival. You see the numbers are completely exactly the same. Well, maybe this will be a kind of tail, as was mentioned earlier this morning, but I think we'll need a bit more time to see if there is some difference at the end. And then P16, which is a surrogate marker for HPV positivity. P16 tumors are mostly those who are HPV associated. So you see that the patients with P16 positive disease treated with nivolumab had significantly better overall survival than those treated with chemotherapy. The difference was here also for the patients with P16 negative patients. And just briefly about the quality of life. In this trial, it was proved via ERTC questionnaires. You can see in red quality of life in the patients who receive chemotherapy, and in blue quality of life in patients treated with nivolumab. So this is, I think, what we heard about this morning. The patients treated with nivolumab has much better life quality, actually report about almost the same quality as the patients, as the healthy individuals. There has been a trial in pembrolizumab. This was a phase 1b trial that included other patients, other solid tumors too, and they were initially 60 patients, and then there was expansion cohort, so at the end there was some almost 200 patients treated with pembrolizumab. What you see here is a response, or as the authors define that as a shrinkage of tumor. You see, this is any kind of decrease in size from the initial size of the tumor. It's not racist, obviously. And this decrease in target lesion was occurred in up to 60%. So these are also very good results for patients with head and neck cancer. And what you can see here is the duration of the response. So you see here that there is a large number of patients still in treatment at 18 months, and some of the patients who stopped the treatment due to progression still alive at 30 months, which again is much better than we usually see in this population. This is just a part of this trial which was published recently in a Lancet Oncology, showing basically not as good results. This was only first part, the first cohort, but still obviously significant response and also rather long duration of the treatment. And last year on ESMO, this data were presented. This is not a squamous cell carcinoma of head and neck. This is nasopharyngeal carcinoma, which is different disease. It has different risk factors. It's caused by Epstein-Barr virus. And those patients, all of those patients had recurrent nasopharyngeal cancer after several lines of therapies. So even in this situation, the results showed a significant part of the patient that showed the shrinkage of the tumor, and as in the other trial, the duration of the response was rather long in part of the patients. Last year, they did not show any data regarding PD-L1 expression, so maybe we'll see that this year. And then oncolytic viruses. They have been around for quite a long time now, firstly reported in the 90s. And the oncolytic viruses are viruses that selectively infect and replicate within tumor cells and lyse them without harming the normal tissue. And the idea of their action is at part the local effect, because they selectively infect the cells, replicate within them, and do this local damage. And the other part of their activity is the stimulation of immune response locally and in the whole body. So there, if you look at the clinicaltrials.gov, at the moment there are 69 trials with oncolytic viruses reported, and around 40 of them are recruiting at the moment. So there are different types of viruses, very different from Rheocoxsackie parvovirus, which are obviously wild type, and then many of them engineered, like adenoviruses, and the most common being herpes virus, with strong lytic properties and a high replication activity. So this is the best known, the best tested oncolytic virus. It's a herpes simplex virus 1. And the name is really not easy to pronounce. So it's Talimogen laherparepvec, and there is a short form. It's called TVEC. And what you see here is how this name actually came up. So it means there is an immunomodulating effect. It's a gene therapy. It's based on herpes simplex virus. It's a replicating virus, and there is a vector. So this explains it, I think. So this is to help us imagine a little bit how this engineering actually happens. There are genes or viral proteins that are deleted. So I will not go to them in detail, of course, but you see that there are proteins, deletion of which has effect in terms of enhanced antigen presentation, enhancement of tumor selectivity, enhancement of replication, or the procedures that maximize the immune response following the release of antigen. And this is basically what's believed to be the mechanism, consisting of two kinds of effects. One of them be local effect caused by the cell lysis by the replicating virus, and another part being systemic effect with systemic tumor response that can cause the death of the metastases. Safety of TVEC is good. This virus has been tested for many years now, and in the trial we had most of procedures where you had to pay attention to were regarding the handling of the family members and the patient, the wound or the place where the virus was injected, to avoid local reactions, maybe local viral infections. And just at the end, to show you where I see challenges when we talk about immune therapy in head and neck patients. I will not go through the history of this patient. You see that he had a local relapse, lymph node relapse. And what you can see here is the extension of the tumor at the begin of the treatment with TVEC. This was a patient who's been operated, radiated, had second lines of chemotherapy, and the tumor was growing, so he was sent basically from another hospital. And then we did one injection of TVEC and one infusion of pembrolizumab, and this is what happened. So now, how do we know if this is pseudo-progression, if it's progression by itself? The problem is for the patient the same. I mean, this is a huge tumor mass. It causes pain, of course. It's made him more symptomatic than he was before the treatment. And in addition to that, he developed sinus venous thrombosis. And now it's difficult to say, does it have to do anything with TVEC or pembrolizumab, or is it something that you can expect when the tumor makes such a compression to veins? So I think that with this population, we will have to really be careful with selections of the patient and try to put them in the trials early when the the lymph nodes or the local tumor are not big as here. But at this point, unfortunately, it's not rare that we see exactly this kind of patients where it's difficult to offer any other kind of therapy. So I would conclude with this slide. Immune therapy is active in treatment of part of the patients with head and neck cancer. Nivolumab improved survival in second line compared with standard of care in phase 3 trial. Pembrolizumab is safe, as we saw in the phase 1b, that actually led to approval by FDA. Biomarker research is crucial, as we heard today already, and there seems to be benefit for both HPV positive and HPV negative head and neck cancer. Thank you very much.